I see my presido is online. The president of King's College Old Boys Association of North America, Bayo Yewole. Please, do you want to say a word or two before we get started?
Okay, can you hear me?
Yes, we can hear you.
All right, just to welcome all of you on this. This is our first attempt at this, and it was a brainchild of Adedosmu, so we're very grateful to him. For those of you who are not familiar with the association, we've been around for about 6 years now. We're based I'm based in the Washington, D.C. area, but our members are based all across America. And we have a number of activities throughout the year. The one major activity that we have every year is a big banquet, which unfortunately had to be canceled because of the coronavirus. So at least one of the ways we can keep in touch and stay relevant is to bring to you events like this. And this particular one is especially interesting because it actually allows us to connect with KCOBs all across the world as opposed to just in the United States. So, so thanks, Ade, for putting this together, and thanks to all the speakers for agreeing to be on this panel. And we look forward to an exciting discussion.
Excellent. Thank you so much for that. So with that, we'll get started. I'll introduce Dr. Babajide Keshinro, KCOB himself, 82, highly accomplished doctor who went to Ahmadu Bello University, I believe, and he's currently responsible physician at Janssen Vaccines and Prevention in Leiden in the Netherlands. And he's very at the forefront of, the final solution to all this, the building of vaccines, which he has done a lot of in Africa and elsewhere. So I'm showing a bio of Dr. Keshinro online there. And if you can get started, Jide.
Good morning, everybody. And thanks, Ade. I have to confess, I'm interested in what you really do for a living because I never told you anything about me, but you know everything about me. So I don't know. And I never put this stuff online, so I don't know where you get this. But it's impressive. It's amazing. And good morning, everybody. I feel so humbled to be part of this panel. And my talk, I was hoping would be the last, is just to explain to folks the whole process of vaccine development and why getting a vaccine for coronavirus is going to happen, and it's going to happen in record time, and that's what's going to make it even more special. So that's just about the background of what I will be. So it's not really specific to Nigeria, but it's just a general picture. And the last few slides will be on the coronavirus vaccine itself. I just sent you a new set of slides. So do you want me to share my screen?
Yeah, I think it's probably better to share your screen. So let's see whether I don't fall down on this. So I'm going to make you a host. I think.
Okay.
Yes.
Okay.
So you are now the host. So I guess you can share your screen.
I don't know if you are seeing my screen. Hear me?
Yes, I can hear you and I'm seeing your screen.
Okay, great. So I'll be speaking about vaccine developments. I'll talk a little bit about the history and the types of vaccines and the impact of vaccines on human development. And then I'll talk about the process itself. And finally, I'll talk about COVID. And maybe in the Q&A, I can take questions about the challenges and the benefits of vaccine research, especially in our environment where there are a lot of doubters, as I call them. A vaccine, by definition, is a substance used to stimulate the production of antibodies and, sorry, I moved away, and provide kind of immunity against one or several diseases prepared from either the causative agent itself or a component of that agent without causing the disease itself. And the word vaccine comes from the Latin word vaccinus, pertaining to cows. It's a very, very interesting story of Edward Jenner. He noticed that during the cowpox outbreak in the UK, people who have had cowpox, during the smallpox outbreak, people that had cowpox never got smallpox. So in 1786, thereabouts, that's on the next slide, he actually took the scabs of cowpox from one of the maids and injected it into a young boy, Phipps as he's called. And the boy got a mild cowpox. So he now got the next person that had smallpox, took the scab and injected it into this boy. And the boy never got smallpox. And that's how the smallpox vaccine development process came about. Since then, there have been lots and lots of vaccines. You can see what I just want to show you about this particular slide is a time frame. As we come closer to 2000, you can see more and more and more vaccines being developed. So there's some echo. I don't know. Is something?
Apart from yourself.
Okay. It's very difficult for me to mute everybody here. I'll just go on, don't worry. So what types of vaccines do we have? We have the live attenuated vaccines. These are very strong immune responses, and they tend to provide lifelong immune protection. An example would be the measles vaccine. Then you have the inactivated or killed vaccines like the pertussis vaccine. They give a weaker response, but those don't have a chance of causing infection. But more commonly now, we are having subunits or purified antigens. And even more recently, you have
the noise is coming from Adetutu. Can you mute yourself, please?
Okay, is it okay now? So, but more recently, what we are having are recombinant vector vaccines. You said, let me just find the person. Sorry, I'm trying to find the person.
The noise is coming from Adetutu Adekoya. Please mute yourself if the host can't mute all.
Uh-oh. Sorry.
Okay. So, more recently now, sorry. We're having recombinant vector vaccines where you have being used now. And then you have a component of the virus being injected in the adenovirus, and then it's used for the vaccine, and that's what I work on using adenovirus 26, but I'll talk a bit about that. But I think the game changers are the DNA and RNA viruses, vaccines, where um, a messenger RNA is produced in the lab and it's put into a vaccine. And so the body now produces the proteins of the virus without actually causing any infection. These have their advantages, but they sound very exciting. But the thing is, they've not been used before. And if they succeed, then we have a big game changer in our hands. I put this slide because I hope there will be a lot of Nigerians on this. I mean, people based back home in Nigeria. One of the things I've heard recently is, look, vaccines are not good for you, even in the Netherlands, actually. And but it's becoming more and more of a problem in Africa that the North is trying to annihilate Africans, so to speak. The impact of vaccines, there's been a great improvement in survival, especially because of vaccines and the economic benefits. This is a slide from the WHO showing really how much improvement we have had. In the last 2 years, actually, things have not been so good, basically because of other problems in the subcontinents, things like Ebola in DRC, starvation, malnutrition. So the benefits are going down, the economic hardship, but then you can't compare it to where we were 20 years ago in 2001. So what are the stages of vaccine development? You have the preclinical stage where people go in the lab and they identify the molecules, test them in animals, and be sure they are safe and immunogenic, and so many things go on there. This is one part of vaccine development that nobody wants to talk about, but this can take years and years and years. And I don't know how they do it, but they are the biggest heroes of vaccine development. They have the clinical phase and then the regulatory submissions, approval, and post-licensure. Usually, I've just put up the slides, the stages. You have the phase 1 to 4. I'll talk about them, but it takes from the preclinical to phase 3. It can take over a decade at the minimum. It can be much more. The other side is that only when you start working with the molecule, you have a 0.1% chance of success of that thing even getting to preclinical testing. I mean, to clinical 50% that to be registered event. So it's still, I don't know how to put it, but you want to say chance, but it's a real tasking process. The phase 1 studies, which we already having for the COVID vaccine, very small number of participants, maybe 80, less than 100, and you're just testing for the safety profile of the vaccine, and you just want to identify maybe the dose that can be used in humans. And then you have the phase 2, which takes more participants up, but it takes about 2 years, and then you're investigating both the safety and the immunogenicity. And then finally, the phase 3, where you are actually checking for the efficacy of the vaccine. Phase 4 studies come after registration, and you are looking at the long-term effectiveness, the benefits, and cost effectiveness. People tend to underrate phase 4 studies, but phase 4 studies have been the undoing of some vaccines. I remember vividly the rotavirus vaccine that was associated with a greater than 1% risk of intussusception after it was registered. Of course, it was pulled out of the market. So that's the importance of phase 4 studies. Evebo, it's RBSV. I put this slide to illustrate how things have changed. You remember I talked about 12 years for a vaccine from clinical phase 1 to the end. Evebo made it in 5 years. It was actually developed by Public Health Canada between 2010 and 2013, but kept on the shelf because it was developed against Ebola. They kept it on the shelf and handed it over to Newlink. And just before the outbreak, Newlink was acquired by Merck. And then we had the 2014-2015 outbreak. So Merck went at breakneck speed, ran phase 1 trials, phase 2 trials almost at the same time, and ran a phase 3 trial all within about 2 years. And that was how they were able to stop the outbreak in Guinea using the ring vaccination strategy. It was the same vaccine that was used in the DRC recently, and it really made a lot of difference. So this happened in 5 years, and that sounds like the record so far. But I believe for the COVID vaccines to make any impact, they are going to have to break this record quite significantly. When I was preparing for this 2-3 days ago, I saw this picture in Sky News, surprisingly, on their website. And it says how coronavirus is powering forward a giant leap in medical progress. Yes, indeed, this pandemic is been very disastrous, but it's also making a difference in the way we think. People are really, really working hard. As of 2 days ago, we had about 115 vaccine candidates identified for the coronavirus. 78 have been confirmed as active and 37 unconfirmed. So from all the database we could look at, we couldn't find much about them. What I want to say about them before I talk about the most advanced ones is that we have so many different types. A few are live attenuated, but just look at the deep blue, the non-replicating ones, the peptide-based ones, and then the DNA coming up, the DNA and RNA. So people are using various innovative methods just to get a vaccine out there. And so far, about 4 of them have moved into phase 1 trial. There's one in the US, Moderna, is a messenger RNA vaccine. Then you have an adenovirus one from CanSino Biologicals, and then there's another one in China, which I just read about 2 days ago. It's also there, but I don't want to talk about anything coming out of China these days. So these are the ones, this table just shows the ones that are well recognized. The thing about the DNA one, the RNA one, is that it's very, very easy to produce. They have challenges of stability, but they are very easy to produce. And that's why one of them is in the market, or is in the phase 1 trials already in the US. Yeah, it's in the US. There are a few others that are a bit uncertain, but we also know that we have protein subunits and the non-replicating viruses in production. And the plan is to have them go into trial in the summer at the latest. And hopefully by the end of the year, we'll have phase 2 results and be able to say, just like what was done for Ebola, rather than doing a proper phase 3 study, the outbreak, which everybody expects to happen again in December or thereabouts, will be the study, in the sense that you will have people receiving the vaccine, or people who have received the vaccine being compared to those who are unlucky not to get the vaccine, or also the ring vaccination approach. But that will probably be what we just have up to the winter to get the vaccine into the market. Is this possible? Yes, it's possible. What makes it possible is that the normal vaccine development process, people don't want to invest too much money in manufacturing. You want to wait for your phase 3 results to come before you go into large scale manufacturing. But with this, it's a lot different. People are investing loads and loads and loads of money. And I know organizations that have pledged up to 1 billion doses of vaccines by December at risk to themselves. So the process is being accelerated. The hope is there. And I think we're going to get there. So in summary, I've talked about vaccines in general. They've been in existence over 2 centuries, and they've made a huge impact against infectious diseases. And they've continued to evolve with scientific advancements. The typical development takes several years, but it takes years, but accelerated development is required and has been shown to be possible in emergency situations. And the COVID vaccine development process is moving quite fast with innovative vaccine molecules. Thank you. I'll take your questions.
Wow, fantastic.
Thank you very much.
Thanks so much, Dr. Keshinro, for that. Can everybody still hear me?
We can hear you.
Yes.
Okay, excellent. So we'll open it for questions. If I may start with one of my own for the doctor. In all these vaccines, their development, availability, and all that, what's going to be the mechanism in this particular case for developing countries like Nigeria to have, just as good an access to the vaccine when it comes out as, anybody else?
Wow. That's a question I don't want to hear. Because so let's not deceive ourselves. He who pays the piper dictates the tune. Governments are investing billions of dollars in this vaccine. The US government especially. They are going to be ahead of the queue. There's no joke about it, but thank God for Gavi, the Global Vaccine Alliance. They also buy these vaccines in large bulk, and then they distribute them to developing countries. But I thought your question would be, will the developing countries want them? I think that's the bigger problem that we are having than will it be available for them? The acceptability of vaccines, it's going to be a major problem. Unless they see that it's worked in other areas, or unless you have a life-threatening outbreak restricted to a part of the world and they see it works. Otherwise, nobody's going to take it. It's the same experience we had with Ebola. Okay. It took a while before people got convinced that they needed a vaccine. When the deaths started happening every day, and that's when people took it seriously. So I think it's more of acceptability than people availability. Yep.
Okay. So I see somebody's raising their hand, Patricia Wodi. Doctor, you're the host now, so okay, I think the person is unmuted. Please go ahead.
Yes, I unmuted myself, thanks. And thanks for that nice presentation. I work in vaccine safety, and I agree, my question actually is related to what you said. The problem we're having is, will people accept this vaccine? And the Ebola vaccine will most likely use a new mechanism like the one Moderna is doing. Do you know if any of them would have adjuvants in them? Because that is an area where we have people raising concerns about receiving vaccines that contain adjuvant.
To the best of my knowledge, I don't think we're going to have the successful one being one with an adjuvant. It's either going to be the mRNA ones or the adenovector-based ones. And the adenovector-based ones are non-replicating. So I don't see a situation where we're going to have adjuvants that people may think are poisonous in one way or the other. I don't think so.
Okay. All right, thanks.
Please go ahead, Mr. Utonye.
Hello, everybody. Ubasinachi Utonye, public health pharmacist.
Thank you, Dr. Keshinro, for that, for the wonderful presentation. I just have a few questions. Number one would be, what was the consideration in terms of viral mutation in vaccine production? I think we are quite aware that these viruses could mutate quite fast and easily. And we're still hearing that even the COVID-19 has possible mutations. So how is this integrated into research, and how would this affect approvals in terms of clinical trials? And that's my first question. Second question would be, this is Moderna should be a DNA vaccine, right? Would it be the first in terms of DNA vaccines in production, first of its kind? So that at least that will be, I think that will be a market breakthrough. I just wanted to get that information. And third one is, in terms of acceptability, what is the plan regarding market acceptance and penetration? How is there anything being commissioned in terms of research, knowledge attitudes of people in terms of acceptance of vaccines? What's being done? Because I always think that in terms, when you come to low and medium income countries, that acceptance has always been poor. So if there are plans or global plans towards strengthening research into how to get people to actually use vaccines in these countries, I guess you can shed more light on that as well. Thank you.
Okay, you can hear me?
Yes.
Okay, sorry. So the first question was about the mutations. So what is usually done in vaccine development is to look for stable domains of the vaccine, of the viruses. There may be mutations, but usually you have stable domains. That has been a major problem, for example, with HIV, where you have various subtypes in different parts of the world. And like the study going on in both the US, Canada, and South Africa, we are using a mosaic vaccine. That's picking different pieces from different subtypes and incorporating them into the vector and giving multiple doses of the vaccine. So that can be a very big problem. We all pray that COVID is not like that. It's going to be a big, big problem if it turns out to be like that. You have to use multiple epitopes. Moderna is actually a company, and if they make it, don't worry, they've not made it. They are just there's actually the first phase 1 trial of an mRNA viral vaccine. If they make it to the market, it will be the first mRNA vaccine in the market, and that's going to be a big thing. Yep.
Okay, so that's fantastic. With that, thank you so much for Dr. Keshinro for your wonderful presentation and answers. We're running a little bit behind time, so we'll need to move now to Dr. Gbenga Ogedegbe of NYU Grossman School of Medicine. He has been, at the epicenter of all this in New York City, at one of the top, medical institutions there, dealing with global health issues. And so he's going to have, very topical and timely information for us. And I believe he also straddles the New York, New Jersey border. So that's, New York, New Jersey, this is where the thing hit for all the world. So if you would pass the host back to me.
Yes, I've done that.
I won't need slides, but I'm wondering though, Ade, thanks for the introduction, whether for sequencing sake, I think if Professor Fotokun goes, what I'll be talking about is really the management and how do we prepare in Nigeria for this. I'll talk a bit about what we're doing in New York City, my institution, and then pivot to what the challenges will look like for any African country, and then talk about what I think we can do in Nigeria or how they're preparing for this, the factors that drive that, and then hopefully share with you what a group of us are doing in trying to see how we can be ahead of the game in case God forbid, the curve hits Nigeria. Because without that details of the clinical presentation and all that, it will be difficult to appreciate what I would say.
Okay.
Is that okay?
So that's definitely a great suggestion. And so we'll move on to the Professor Futokun. Please go ahead. Hang on, let me try to, I don't know what people are saying. I think I'm still showing my picture. I'm trying to show the professor's bio.
Yeah.
Dr. Keshiro, did you pass the host back to me?
Yes, I did. You are the host.
Okay. Please pardon me for a moment. Let me see how to deal with this. Okay, excellent. I believe everybody can see Professor Igo Ofotokun's picture and bio. The professor, is a professor of infectious diseases at Emory University, my old home in Atlanta. Way to go, Prof. And he's done, fantastic work in HIV/AIDS concerning women and in Africa and other developing countries. So, as an infectious disease expert, this is really his domain. So, Professor, please go ahead.
Thank you very much, Ade, and thanks for the forum for inviting me to share with you. I consider it a privilege and an honor. And so while I am doing that, I'm going to try and see if I can share my, so you can start sharing why the other participant is. So if you unshare your slide, then I can go ahead and share my slide. Are they, okay.
Okay, I just did that.
Okay, so I'm gonna go ahead and put up my slide. Let's see here. I think this is what I want. Let's see, can you all see my slide?
Yes,
my screen?
We can see it.
Okay. Let's see. So you can see my screen now?
Yes, we see a picture of you and also your presentation. Okay. A video of you and also your presentation.
Okay, let me see if I can, let me do this. Now you see my screen? You see my screen?
Yeah, I mean, this is fine. We can see your presentation. You just need to, on that PowerPoint, you just click the button to expand your screen.
I have so many screens and I think that.
Oh, okay. You have multiple screens there. I see.
Switch to the right one. Oh, is that better?
Yeah, that's better. So it's showing us your PowerPoint and then your video. So this is good. Let's go ahead.
All right. Thank you so much. What I thought I should do is to just talk about the virus itself, what the virus looks like, how it does, a lot of the things it does, so that you all can take into perspective a lot of the things that we in the So our knowledge of the SARS coronavirus 2 is limited. So we hear a lot, those of us who deal with this aspect of medicine, they are learning just as much as the general public is learning. So this slide here was taken, this was a picture of us in January of this year. I think it was on the 1st. So we were in DC at the NIH headquarters.
Professor,
yeah.
When you lean back, the audio is better. When you lean forward, the audio is not very good.
Okay.
When you're back, the audio is better.
Okay, good. So this was, I was saying that this was us in DC when the Infectious Diseases Clinical Research Consortium of the NIH was inaugurated. This was the 21st of January. Then Tony Fauci, who is the director of NIAID, was there. And that was at the time that we were beginning to hear of the coronavirus. virus and what was going on in Wuhan. And Tony Fauci left that meeting on that day and said this epidemic might be big and that he couldn't stay with us for the entire day because he had to go to the White House. They were planning on strategies of what the impact of the epidemic would be in the US. I remember when
we're not hearing you well, though.
Can you hear me better? Can you hear me?
Yeah.
Okay. Okay. So what? Why I show this picture is just the irony of life. On the 21st of January, we were taking this picture. I remember the photographer was telling us to get us to smile. He said we should all say Wuhan, and we all say Wuhan. We didn't know that this was going to turn into this major epidemic that is going to impact the entire world. So this group is actually responsible for a lot of the trials that are going on with regards to treatment. The severe trial, the phase 3 trial that is going on currently that will be completed at the end of this coming week. And also the Moderna vaccine, we just finished phase 1 and we are in the process of going to phase 2, phase 3. So this group is really running the show, trying to get both treatment and vaccine for the US and hopefully for the entire world. So we all have seen the various of the virus. I hope you're still hearing me. I think, is that good? You're still hearing me?
Yes, we can hear you.
Wonderful. So it gets its name from the crown, the spike that we all see projected in the news. Coronavirus has been with us for many years, thousands of years. About 10 to 30% of all the cases of common cold are due to some strain of coronavirus. They replicate at lower temperature, and that is why they have evolution for the upper respiratory tract and the respiratory tract where the temperature is slightly lower. The crown or the corona or
sorry, we're having difficulty hearing you. We really can't hear you at all.
Okay.
So I'm not sure whether you have a microphone near you or something.
Yeah. Can you hear? I have a microphone. I'm so close. I don't know if it has to. Can you hear me now?
Well, right now we can, but you know, so at some point we stop hearing you. I don't know. Maybe you just need to.
Okay. I will stay in this position and see if that works. Perhaps it also has to do with fluctuating internet connection and the traffic. I was just saying that the envelope is required, the spike is required for the survival of the coronavirus because it uses the spike to attack surfaces. The control of transmission is difficult, as we all are seeing every day. So there are 7 species of the coronavirus that have been pathogenic to humans. 2 of them are known to cause the common cold, coronavirus 229E and OC4. We also have the M63 that causes disease in children and immunocompromised patients. We have the KLU1 that causes respiratory disease during the winter. So 3 outbreaks have resulted from the coronavirus. One is the SARS-CoV-1 that started in 2002 in Guangdong province in China. Actually, China had a head start with coronavirus because during the 2002-2004 epidemic, there were almost more than 8,000 people were affected, and it led to about 774 deaths among the confirmed cases. Then in April of 2012, we had another outbreak in Saudi Arabia. That led to about almost 2,500 confirmed cases. And then, of course, we had almost 851 deaths. So the mortality rate from the 2000.
Do you see my messages?
Yeah. Are you still hearing me? I'm surprised you can hear me. Can you still hear me? Hello?
Yeah, I can hear.
Yes, we hear you, yes.
So okay. And now we have the current outbreak, which is causing a major pandemic. So the current outbreak started in Wuhan. And the reason why this is important is because of where Wuhan itself is. So Wuhan is a major city. It's in the central of China, is the capital of Hubei province. Wuhan has about 11 million people, and it's a major commercial city. People travel from all over China and all over the world to Wuhan. So in November of last year, so there were cases of pneumonia, and then a lot of people were dying. And this pneumonia was traced to the wildlife or seafood market in the center of Wuhan. So by the 31st of December, the country office of the WHO in China was notified about these cases of pneumonia. And then by January, the Chinese as well as the US's CDC have isolated the cause of this pneumonia. And at that time, it was referred to the 2019 novel coronavirus as a specific agent that was isolated from 3 individuals that had this pneumonia. In February, the name COVID-19 was coined for this disease, so as not refer it as a China virus to stigmatize Asian. And then the name of the virus was changed to SARS-CoV-2 to distinguish it from the COVID-1 that occurred in 2002 in Guangdong province in China. We all know that the death rate, nobody can keep up with the number of cases. It's rising significantly every day. The death rate is also rising significantly every day. We know it's now transmitted from person to person via air droplets and also by contacts. So this is what the COVID-19 virus, SARS-CoV-2 virus looks like in structure. So it's a very simple virus. It's an RNA virus, kind of similar to many RNA virus. It's a positive sense single-stranded RNA virus. Like I said, it was first isolated from 2 individuals with pneumonia from Wuhan, and it is believed to have zoonotic origin. The genetic material is similar to those of bat coronavirus that are found in China. So we think that this virus emerged from the bat, but there was an intermediate host before it got to human. And people think that this intermediate reservoir is the pangolin, the Chinese pangolin, which is a very popular bushmeat in China. So the structure includes 4 structural proteins. So you have the spike protein, the membrane protein, the E protein, as well as what we call the N protein or the nucleocapsid protein, as well as the envelope protein, which are kind of represented on this slide. So the spike protein is responsible for allowing the virus to attach and fuse to the membrane of the host. It uses the spike protein, this strand that we see on TV every day, to really establish infection. Whereas the N protein, which holds the genetic material, really is what the virus uses to replicate itself. We'll talk about it a little bit more later. So the spike, the envelope protein, and the membrane protein forms the thick glycoprotein layer. So people think that this the cell wall of this virus is mostly lipid, it's a glycoprotein layer. And so this, the recommendation that if you wash your hands for 20 minutes with soap and water, is that the soap and water will emulsify the wall of the virus, and break the virus and kill it if for some reason you are contaminated in your hands. So how does the virus establish infection? So what we all now know is that the spike protein really latches to the receptor in the body, known as the angiotensin converting enzyme receptor 2. So it latches with the spike protein, and then and then there is a second protein that is involved in this. But one thing that is unique about the COVID-2 virus is that the affinity of the spike, the binding side, the binding domain of the spike protein for the ACE receptor, the ACE2 receptor is extremely very high compared to the previous outbreaks that we had in 2012 and 2002. So after attachment, there is then the binding site really is, and this cap is removed by another protein known as the transmembrane protein 72. So the transmembrane protein will uncap the fusion domain and then allows the virus to fuse with the whole cell wall and is then internalized by the process of endocytosis. So once the virus gets into the body, it releases its genetic material, the RNA, into the cytoplasm together with other polyprotein, PP1A, PP. This is cleaved by a protease enzyme into the RNA-dependent RNA polymerase. The RNA-dependent RNA polymerase then converts the genetic material, the positive sense RNA, to the negative sense RNA. And then from the negative sense RNA, more genetic materials are produced, positive sense RNA are produced. And also the expansion of this negative sense RNA to a shorter segment of RNA known as subsegmental RNA. And from this subsegmental RNA, the various structural proteins and the functional proteins of the virus are produced. Together with new RNA that are formed, this is packaged in the endothelium reticulum and Golgi apparatus into the new virus, which is then released into the site circulation. So millions and millions of viruses are released immediately following establishment of infection, and viruses are circulated into almost every cell's tissue in the body. We will talk about that more shortly. But you see high viral load in the blood, in the respiratory tract, even in the GI tract immediately following establishment of the infection. So once the virus gets into the upper respiratory tract, it attaches to the receptor, the ACE2 receptor immunocyte 2, and we have abundance of these receptors in the respiratory tract. So some of these cells are destroyed, and these stimulate what we call inflammatory response. So those inflammations damages the lung and also stimulate a lot of the systemic symptoms that we have with this virus. So people present with the clinical presentation of dry cough. Some people will have sore throat. Others will have aches. And usually, in a vast majority of people, about 50% of individuals, the immune response is able to contain the virus, and so they resolve the infection. However, in a very small percentage of people, about 18% of people, this immune response becomes exaggerated, leading to what is referred to as the cytokine release syndrome. So the cytokine release syndrome leads to excessive damage of the alveolar epithelium from the host self-immune system. So this leads to the release of a number of cytokines, including IL-4, IL-6, GM-CSF, TNF-alpha. And what this leads to is the edema of the epithelial surface, fluid accumulation, and subsequent formation of fibrosis. And this really impairs gaseous exchange and treat the individual to the acute respiratory distress that we see in the fraction of the individuals infected with COVID-19. So the incubation period of this virus is estimated to be between 2 and 14 days. These were all generated from data from China. Some individuals can get sick on the same day they are exposed. Others actually get sick about 30 days after exposure. But on the average, majority of people who develop symptoms about within 5 days of being exposed. And this knowledge, this data actually informs some of the CDC guidelines on return to work for health workers. So what is the risk of COVID infection? Why? What really increases the risk? Why is it that some people get infected easily? Why is it that some people get symptoms and others don't get symptoms? Why is it that symptoms is milder in some people and more severe in others? Again, we really don't have the answer to all of those questions, but the speculation is that the distribution of the receptor that the virus binds to varies from individual to individual. First of all, the receptor is distributed abundantly in the lungs. So that is why the first presenting symptoms are usually respiratory tract symptoms, upper respiratory tract, and then pneumonia. There's also the distribution of the ACE2 receptor in various organs and tissues in the body, especially the GI tract. There's about 100-fold concentration of the ACE2 receptor in the GI tract. So some people present with GI symptoms like diarrhea, nausea, and vomiting. We also have the angiotensin system in the renal and also in the endothelium. So people, we are beginning to see that some people present with hemophilia. We also have cardiovascular shock as a presentation. And one thing that we're seeing increasingly is thrombosis. Thrombosis of both large, medium, and small vessels. And the other thing to really note is that there are variants of this ACE2 receptor. There are genetic variants. There are 6 genetic variants that have been characterized. And it seems like the distribution, these variants affect the distribution in this receptor in different populations. And as I have shown on this slide, you can see that there's really abundance of this receptor among patients, and then less so among whites, and less so among blacks. A number of other factors also affect the distribution of this receptor, for instance, sex of the individual. So the gene that encodes from the angiotensin II receptor is encoded in the X chromosome. Remember that women have 2 X and men have an X and a Y. So if there's any genetic variant, it will be recessive among women as compared to men. So there has been also speculation that comorbidities such as hypertension, even the use of some of the antihypertensive drugs, cardiovascular disease, chronic lung disease, age, all affect the distribution of these 2 receptors that could affect severity of illness. And as we have seen in the news, people who are likely to die or succumb to this infection are older age individuals. We also know that the sex differences in the severity of illnesses. Male are dying at almost 2 times the rate of female to this infection. And we know that comorbidities, including cardiovascular disease, diabetes, chronic respiratory disease, hypertension, play a role in the outcome of this disease. So this was a slide that I received from Yele Amiko a few weeks back, looking at the distribution of COVID and the distribution of malaria. So we would consider this, if you were a chemist, you would think this is like, this is a mirror image, an isomer of each other. So when you have COVID, you have less malaria. When you have malaria, you have less COVID. We really don't know what this means yet. People have associated it with malaria and COVID, chloroquine use and COVID, BCG use, and all of it, but I thought this was really fascinating and interesting. It's something that we will keep our eye on. The other things, those of you who have been following the news, I think I got this slide from MSNBC, is the ratio disparity in the death of COVID, death rate of COVID in the US. Black are by far more likely to die from COVID. In my hospital, for instance, 80% of all the blacks have been 80% of all the deaths have been among the black individuals. People have associated this to the disparity we have in healthcare delivery, the comorbidities we see among black. These probably are all true, and I'm sure we will continue to study or learn more about it. I just wanted to look at the differences between the current SARS outbreak and the previous outbreak that we have had. COVID-1 outbreak in 2002 and the MERS in 2000. You can see that mortality rate from these previous epidemics, but the transmission rate is extremely higher in COVID-2. So there is the reproductive number, which is the number that of individual that can index this infect. In COVID-2, this virus has a significantly higher reproductive number of anywhere between 2 and 4. Whereas with MERS, we had a reproductive number of less than 1. That is probably why fewer people were infected and it was contained within the Middle East. With SARS-CoV-2, we had a reproductive number is around 1.4, and that is why probably it didn't spread across the globe like we are seeing in the current. So a couple of questions that I just wanted to raise out there that have come up and that we hear about in the news. Why are some individuals more susceptible than others? So age, sex, comorbidities. Again, people think this has to do with genetics. And then, of course, has to do with comorbidities. So like I've said earlier on, the receptors that the COVID virus binds to there are genetic mutations in distribution of the receptor among different groups of people. For example, we know women now, if there is a mutation, women are likely to be recessive and therefore the effect of that mutation will be blunted. And we see that the outcome of disease among women is significantly less severe than among men. So why is the virus spreading so rapidly? So this is a three-dimensional picture of the spike protein and the binding site of the spike protein. And the thing we are now beginning to find out about this protein is that the affinity of the receptor for this binding site, the spike protein, the receptor for the SARS for COVID-2 is extremely higher, about 10 to 20 times higher than that of either the MERS, which binds to another receptor, or SARS-CoV-1, which binds to the same receptor. So the implication of that is that you require a very small inoculum of the virus to establish an infection. Because a little exposure would lead to infection. It looks like if we were going to design a virus to affect the world, this would be a perfect design. And that is why the reproductive number for this virus is extremely high. So the other question is, why is this virus so deadly in certain individuals? Again, we don't know. We know that what really drives death in people is the cytokine release syndrome, where people mount immune response to the virus. Some people mount the appropriate amount of immune response, other mount exaggerated amount of immune response, and it's this immune response that leads to the active respiratory distress syndrome, the vascular shock that we see, the acute kidney failure that we see in some individuals. So I'm just going to end with, this is my last slide, talking a little bit about treatment. So development of treatment for COVID-2 virus. So we now understand the life cycle of the virus. We know it gets into the body using the phase 2 receptor. We know that the genetic material is then transcribed to RNA, which are then transcribed into more RNA, and then there's also protein synthesis of the RNA-dependent polymerase, and then there's the packaging of the virus in the virus. So the number of agents are out there, so the principle of treatment is two. So you have the virus itself, and then the treatment for the cytokine storm. So we're looking for agents that can inhibit viral replication. We're looking for agents that can prevent the cytokine storm. So many agents have been being developed. The one that has gone very far is the remdesivir that is produced that is being manufactured by Gilead. It was a drug that was developed for the treatment of Ebola, but we are now finding that it has a lot of strong different activity against COVID-19. We are in the US working with the NIH. We are the one coordinating the phase 3 trial. Recruitment into that trial will end this coming week. And I'm sure by the end of the month, we will have the results of that trial. So people have speculated that by blocking the ACE receptor, the ACE receptor will also be in the virus cell. A lot of studies are ongoing, particularly in non-human primates, to look at whether this is an effective way to treat the virus. There have been studies that have actually looked at protease inhibitors, the one we use for HIV treatment. One looking at the other was tried in China, was a failed study. Suspect other pathways that inhibited, including the release of the virus. So all of these studies are ongoing, but the one that has really gone far is the use of the other study that is also ongoing currently is the use of IL-6 inhibitor to prevent the cytokine storm. So working also with Lilly, they have an IL-6 product that we think is potent. So there's a phase 2 trial that is in development also at the IDIC together with the NIH to look at the combination of IL-6 inhibitor with we are also involved with the Moderna vaccine development. The phase 1 trial was completed last week. We are now in the process of preparing for phase 2, phase 3 trial, and hopefully that will roll out extremely soon. We don't have the result of this one trial yet, but we hope to have that sometime before the end of the month, and we are making expeditious plan to roll out the phase 3 trial. So I will end with this slide. So I just, the point here is that life may never return to the same again. This is my prediction. We were having our staff meeting last week, Friday, and everybody has gone on the meeting from their different places in the city of Atlanta. So hopefully we will have good treatment, hopefully we will have good vaccine, but I don't think that this virus has come to change the way we live life as we normally know it. So it's going to be interesting to see what happens when all of this is over. And I'm very confident that at some point, this is going to be over. So thank you very much for your attention. Sorry for the instability of the Zoom connection. I hope that you were able to hear most of what I was saying. Thanks.
Well, Professor, that was fantastic. Really tour de force of education. Really, thank you so much for your time and your knowledge that you've shared with us today. So opening it up to questions now. If anybody, folks have questions for the professor, please unmute yourself and go ahead.
Yeah, I have a question.
Please go ahead, Mr. Ikenna M.
Sure. Professor, I really enjoyed your presentation. It was really enlightening. So my question is this, actually, maybe it's probably two questions at this point. You had a slide where you showed this almost 10-year cadence with coronaviruses. Can you speak to that? You know, we had SARS, we had MERS, and now we have COVID-2, and it seems to be almost this kind of like 10-year gap. Can you say something about that?
It's interesting that it's actually in 10 years gap. We have actually noted that maybe what's going to happen 10 years from now. I don't know if I think it's just a matter of coincidence.
Right.
Somebody actually pointed out every 100 years we have a major epidemic. In 1918 or so, we had the Spanish flu that wiped out almost 50 million. And the year before there was the bubonic, 100 years before there was the bubonic. We don't know if there's any relationship to this, but this is just off incident.
Okay. I think I got some of that. So my other question was, so you had a slide about potential therapies, right? And obviously at the top of it, actually maybe a little bit removed from IL-6, you talked about protease inhibitors like TMPRSS2. Are there others in consideration? Because as you know, SARS, COVID-19, and SARS from the 2000s, they can gain entry using trypsin, furin, and a couple of other host proteases. Are there any developments that can target that?
So this slide shows the potential targets.
Yeah.
Most of the targets, most of the drugs, there are several drugs now that are being in development. So 19 is actually involved in the development of one of those drugs. The protease inhibitor, so remember what the protease inhibitor does. When the cells release their current genetic material into the cytoplasm, they also release the polyprotein. So the polyproteins are cleaved by the protease inhibitor into the polymers.
Sorry, I'm losing you again on the audio.
Yes. Can you hear me?
Yes, that's better.
Yeah. So the protease inhibitor prevents the cleavage of the polyprotein into the proteases that are involved in RNA transcription. So the speculation is that some of these protease inhibitors will be effective by binding the proteins. It will prevent this.
So my question was really about the proteases that that play a role in viral entry. So you have TMPRSS2.
Yeah.
And so also there's there's trypsin that can be found in the lungs as well, and then there's furin. And I'm sure, as you know, with the SARS spike protein and entry points in terms of the cleavage to expose the fusion peptide, those markers are very specific for either trypsin, furin, or now TMPRSS2. So my question is, are there other protease entry inhibitors in development right now, aside from this TMPRSS2 targets? And the reason why I ask is it's very, so if you see how the virus, is getting better and better at gaining entry and in transmission, you would almost kind of, guesstimate that the virus would also be picking up other additional entry host partners. I was wondering if people are thinking about it in that way.
I am sure they are. Everything is a game at this point. I am not aware if anybody is developing targets. What I'm aware of is that there are attempts, because most of these are animal studies that are looking at.
Of course.
Blockers to see if they can block these cells. If you look at the WHO website, there are about 500 different clinical studies. And if you look at clinical trials, there are about 200 clinical trials.
Sorry, I'm losing you again.
Yeah. So what I'm saying is that there's a lot of clinical trials that are ongoing,
right,
and everything is being at this point.
Okay, and then so I have one more question, and I'll drop off. You also had a really nice slide where you talked about the most susceptible folks. Are there any kind of studies in play right now that kind of link outcome to genetics? So basically, if can I look at your sequence and say, hey, you're probably predisposed to SARS-CoV-2 as opposed to person X or person B? Is that anything in play at this point?
Not that I'm aware.
Okay.
Clinical information that we have, that people, elderly people
right.
People that are living compromise, there's no study.
Okay. All right. Thank you. Thank you very much, sir.
Thanks.
This is.
Thank you, Doctor. Okay, Dr. Adesanya, please go ahead.
You hear me? Professor Igo, Thank you for your presentation again. I just wanted to, can you guys hear me clearly?
Yes. Yes. Yes.
Right. I just wanted to comment on the question with regards to therapies. I think that was pushing you to the wall because the whole known wide world of therapy is actually the NIH pharmacology division might be able to give a much better perspective with regards to what the wide world of therapies will be. Maybe China that's gone ahead of us in this thing, but right now I think there is a distrust for anything coming out of China. Finally, I'm terribly surprised as to the fact that the U.S. government, either through FDA or NIH, has not partnered with pharma to aggressively tackle this thing. And there's still a whole lot of individual effort either by the US government or the pharmaceutical industry. I'm curious to know, Professor Igo, what is the status of the US government vaccine research that is being led by Dr. Kismia? Do you have any comment on that?
Yes, so this is the Moderna vaccine, the RNA vaccine that is being developed. So the IDC ROC is actually leading that effort in collaboration with GMID, which is a division of NIH. So we are the leadership group. We are the one really coordinating that effort. I mentioned earlier on that we just finished phase 1 last week. So all the data, phase 1 was done here in Atlanta and also in Seattle. So it's completed. So we are now preparing for phase 2 and phase 3. So phase 2, phase 3 is going to be about. So phase 2, phase 3, the plan actually is to target about 5,000 people from 60 sites across the world, so the US, the international sites. And one of the discussions we had in the call on Friday, that was one of the discussions is which population groups we have. So we still have those questions. We don't have the result for the phase 1 yet, so it's probably going to be just the need to utilize whether the vaccine was able to generate. We don't have those results, but I have a feeling that somebody already has seen those results. That we do not progressing to phase 2. So this is very rapidly, and we enrolled, we developed and enrolled the phase 1 study within a period of 6 weeks. So we expect that phase 3 is going to take, with 60 sites across the world, we expect that it's going to take a very short time. In terms of therapeutics, of development, we are the one working with units to develop the remdesivir. So the phase 2 study, we've enrolled about 700 people. It's going to close this coming week, and by the end of the month, we have the result. There will be definitely result for the remdesivir trial. The effort is not uncoordinated, so we are working behind the scenes. There are, so with the leadership with the IDC, ROC, and NIH, we are receiving a lot of data from pharmaceuticals. There are at least close to 30 applications that we are currently reviewing. With all different people that are feeling that they have drugs and are effective against the coronavirus. Some of them are antiviral drugs, some of them are anti-inflammatory agents, inhibitors of IL-6. So there are things going on behind the scene, and we are moving extremely very fast. What you hear in the news, it's not exactly how things are being done, and they are being Tony Fauci is at the center of this. It's very much important.
Okay, thanks so much, Professor. This has been fantastic, and thanks also for the excellent Q&A questions. I can sense that, given that a lot of the questions went over my head, I can immediately sense that there are lots of experts on the line. So you know, I just wanted to make a short announcement. Our last speaker, Dr. Ikenya, unfortunately had to go because we're running behind, and you know, he had a very tight time slot. But since we're, you know, a little bit behind anyway, it probably doesn't matter too much. So we're going to let Dr. Ogedegbe go ahead. Doctor, before you go, I wanted to thank Dr. Chinwe Ogedegbe for joining us. I understand she's also, you know, in the emergency medicine in New Jersey. Am I correct?
Correct, you're correct.
Yeah, so we would love to hear from her. She's really, you know, the frontliner of the frontliners.
Okay.
And
Right.
thank you so much. It's wonderful.
Thanks.
At the work you do.
Okay, I'll try to make it brief. You have to mute. Sure.
I will.
And before I do that though, there's somebody hiding in the audience, Professor Yinka Lutoye. His handle feed says Yinka, the physician in charge at Ohio Children's Hospital, old Casey boy as well. So shout out to Yinka. But let me bring this back down. Thank you very much, Ade. Thank you, Igo. And of course, thank you to Dr. Keshinra as well. What I thought I'd do is, now that you have a good sense of what is going on, I wish Ike was online because it would have given us a better flavor of what's happening in Nigeria. So before I do that though, I'll try give you a good sense from my perspective, some of the consequences of COVID-19 and its impact on preparedness. So why did I get interested in this? I am not an ID doc. I'm a plain old internist or primary care doctor, the lowest of the ranks, as you can imagine. We're not specialists. But I got involved in this because in New York City, this stuff is real. It's not a joke. We have our hospital alone, we have 3 systems, one in Brooklyn, one in Long Island, and one in Manhattan. We've screened about 18,000 patients just in the past month and a half. So it's not a joke. We've admitted probably half of them. So you can imagine that all of a sudden, things that we didn't used to concern ourselves with became much more important. Everywhere is an emergency ward. Created new units, created new wards. And it got me thinking, with our governor talking about the need for ventilators, a major crux of treatment for these patients is really oxygen therapy. The idea is that 80% will do well, 20% will have symptoms. About half of those, you're going to admit them. And when you do, maybe about 10% of them will need oxygen therapy, and 6% may just not make it. So when you look at that number and you project that out, you begin to wonder, if this hits Nigeria, what are we going to do? So my talk is to give you a sense of, you know, what is the threadbare issues that we have to think about from the point of view of Nigeria. For New York City, some of us were very concerned about what to do. And we did what we can do best, which is research, for some of me and my colleagues. But others said, you know, research is good, but the problem really is we have to get the ventilators. And it became clear quickly earlier on that we've got to figure out a way to get ventilators. In my hospital alone, believe it or not, we only have about 50. You don't need more than 50 ventilators because you manage people very aggressively before you get to that stage. But we had to intubate about 300 people very quickly within the course of 2 weeks. So people started thinking about converting what we call CPAP machines, BiPAP machines to ventilators and figuring out innovative ways. So I started thinking, we're not going to have ventilators in Nigeria, but what are the threadbare issues that we have to think about to be able to address that? So here it is. I think there are 3 major categories of burden that threaten to make the consequence of COVID-19 pandemic in Africa, regardless of the country, not even South Africa is spared in this one, exponentially more serious than elsewhere. The first one is disease containment. So how do we actually find people, track them, and keep them and quarantine them where they are? The second one is the healthcare infrastructure. And the third one is what we call the disease burden, or what they call the chronic diseases, as Professor Tokun actually showed you. What you tend to see there is that there are people who have certain kinds of diseases that are predisposed to this. Dr. Keshinro talked about the whole idea of the vaccine. I think that's long term. We may get it sooner, great. But before we get there though, what will we do in Nigeria? Here are the things that will make it difficult for us to address this issue rather quickly. But if we think about them, we can begin to actually, because we're coming late in the game, we can begin to figure out what to do. So for disease containment, most countries do not have the capacity to quarantine those affected. So if you look at even here in the United States, who are the people working from home? The majority of those working from home are privileged people. We're all privileged. We're home, we have wireless access, we can dial in, we can do, I did telemedicine for some of the patients, we can do all of that stuff. But the majority of people really don't have that stuff. So you probably heard about the fact that in New York City, in Milwaukee, in Chicago, that most of the patients in Louisiana, I think as well, that are actually dying from this are Black and brown people, African Americans. We are looking at the data in our system. We have 18,000 people screened, half of them positive, a third of them are Blacks or Latinos. We're finding the same thing. The question is why? And the reason we're thinking is because if you map the zip codes of people, which is what we did, we took the addresses, we looked at their zip codes, and we begin to appreciate the level of socioeconomic status. So how many are living below poverty level in those regions? How many are minority populations? How many live in crowded rental apartments? And what is the median income in that population? And what's the educational status? How many folks have cars in those places? I can't share that data quite yet, but preliminarily what we're finding is that the bulk of the problem is coming from those regions. So you're going to ask me, why is that related to Nigeria? Here's why. 40% of people in Africa live in urban slums. So if you're from Lagos, you're going to talk about Ajegunle, although that's a bit different now. You're going to talk about Makoko. You're going to talk about Morocco, a lot of places where you don't just have the infrastructure, the density there is very high. So your ability to actually effectively quarantine people becomes very difficult because they share living and working spaces, and quarantine is just not an option. So that's number one. Number two for disease containment is economic hardship due to a consequence of social distancing measures. I mean, we want to identify, we want to track people, and want to contain them in space. In our setting in Nigeria, it's going to be difficult. I hear they're doing it now. People are on lockdowns because 1 out of 3 Africans live below the poverty line. And if you think about it, most actually will consider on welfare. So isolating them is like food deprivation. I hear some states are beginning to give food. This is why I wish Ike was on the call. They're beginning to give food to their local constituents, but it's very difficult. Again, these are issues that if we think about it, if we plan, we can probably begin to address them. And then third, under disease containment is the basic practices to prevent the spread of disease are often not possible. We heard about hand washing. I mean, I don't know about you guys. I mean, if you really grow up in an urban area, water is a privilege. And you really have to be very creative in getting water. There's pure water sold all over the streets, but the idea then becomes, how do you pay for water? And you're going to use that water to wash your hands. So it's easier said than done, but these are things we have to start thinking about. The second issue then is the healthcare infrastructure. I'm preaching to the choir here. There's nothing I'm going to say here that is new to you. Let's just run through some data. In Africa today, we think, at least in sub-Saharan Africa, 11% of the global population is there. That's what we constitute there. And 24% of the world global disease burden is actually there. So it's overrepresented in terms of disease burden. But the real key figure is only 3% of the global health workforce are in sub-Saharan Africa. So you have a higher burden and you have a much lower burden, much lower healthcare workforce, as you can imagine. Let's put some numbers to that. So if you think about COVID-19, we're talking a lot about the idea that we have to have ICU beds, right? If you think about shortage of healthcare workers, globally, the WHO requires about 23 health professionals per 10,000 population, maybe more. Most African countries have only 5. Nigeria, we have 1 to 5,000. And the 1 to 5,000 that we have per population are mostly in urban areas. So when you paint that picture, begin to appreciate how difficult it's going to be if we don't begin to think about these things proactively. ICU beds, I think the data is that you need about in Africa, you have less than 1 to 100,000. US has 20 to 100,000. I believe in most of Europe is 4,000 to 1 million. They say most of Africa less than 5 per million. So we're not going to get to the issue of ICU beds. We've got to start getting creative. And I'll talk about some of the things that we're beginning to think about. And then finally is the disease burden. So the idea is that we still have a very high rate of HIV. It's not going anywhere in most of our work. I think Professor Fortokun, that's really the most of the focus of his work for the most part. So in that setting of high levels of things like HIV, TB, a little bit on the downside, but it's still there. We now begin to see a rise in the burden of what they will call non-communicable disease, hypertension, diabetes. I don't think obesity is that much of a problem yet. Still, it is of the affluent in Africa. Chronic respiratory illness. A major cause of death in infants is still pneumonia, believe it or not. So in the setting of all that, and we know that these are the folks that are going to be much more premorbid, right, or susceptible to getting the COVID-19. We will be waiting for a disaster to happen if this ever gets to us in Nigeria. The second thing to think about under disease burden is we're also beginning to see that if you really think about it, in most of the urban areas, we're seeing a lot of disease that we didn't have to see before. They're getting much more. In 1994, it was a long time ago, my uncle passed away from hypertension and he had to be dialyzed. We could only find 3 dialysis units in Lagos. You fast forward to today, most major streets, you can get dialyzed if you want. What does that mean? We're seeing a lot of chronic kidney disease. And that's not an accident. It's driven not only by high blood pressure, but there's a lot of data showing that there's not something called the unknown chronic kidney disease. It's a lot of environmental toxins. So why am I talking about these things? I'm talking about this because if COVID hits, right, when it does, then we're going to really have a lot of problems. So what are we thinking about in trying to address this? We've had Ebola, right? Dr. Dadava, may also rest in peace, Stella. And his group in Lagos did a fabulous job of contact tracing. So I think we're beginning to still continue to do that. Number of cases now, I'm looking at the paper, I took notes from the website this morning, 442 cases, most of them in Lagos, about 13 deaths. That's on the backdrop of about 19,000 cases in Africa. Last week was only 1,000, so we're beginning to see a steep rise with only about 1,000 deaths. I think it's coming. The good news for us, frankly, and I'm still puzzled about why we haven't hit this yet, is that only about 5% of the population is elderly. And most of our elderly are not going out that much. And because we have that, I think that may stave off, if you may, the impact of the disease. But our young, a lot of our children are not, they're not that healthy either, if you really think about it, given the environmental toxin and what have you. But if the model stays true, that this affects mostly elderly people, then, we may just be okay. The things we're thinking about here, a group of us, some of my colleagues from my university, we've begun to actually solicit. New York City now has, we think, the CPAP machines are how people use to breathe when they sleep at night for obesity, and only 50% of them are used. We have access to about 10,000 of them right now. We think we can get up to 1 million because New York State, after all, did not need all those ventilators and they had purchased a large number already. What we're hoping to do is to source that, and then we can get them to Nigeria. But it turns out we need to get permission from the Presidential Task Force. I'm worried for two reasons. If we're slow, God help us. If we're lucky, we'll get beyond the hump. But here is the problem. When you get beyond the hump, travel is going to increase again. Once travel starts increasing, a lot of people go to China, go to Europe. We're going to see, as people have been saying, we may see another wave. That other wave, it may be mitigated in the high-income countries, but I worry that it may be a problem in places like Nigeria and other African countries. Oxygen therapy is not standard in Nigeria. We can't even have transportation that is good enough for oxygen cylinders. So we have to use oxygen concentrators with cannulas. That's okay. How do we make that systematic? You don't have people that are even trained well to handle these machines. So we formed a consortium where we have access to the machines. We have access to all of the medical device companies that are here. We've solicited some of them. They've agreed. We'll get the protocols that we need for the training, and we'll see if we can marshal through some of our contacts in Lagos, some of the CDC fellows to become trainers. So we can train a whole host of people. We call that task shifting, where we're training non-physicians to be able to manage these machines. After all, people manage them here in their own homes. And so those are some of the things I've been working about. I can't say much about it yet because we're only now in the formative stage, but we think it's going to happen. The second thing that then happens is if we're free of this, hopefully what will come out of this crisis is the innovation that we may have a better sense of how we deliver oxygen therapy in Nigeria, at least for those children who die of pneumonia that we ordinarily don't know how to manage. I'll stop there, and probably I can answer questions and probably delve more into some of the details. Thank you very much.
Thank you very much, Professor. That's wonderful and practical. It's open for questions now, but maybe I'll go with one of mine first. Can everybody hear me?
Yes, we can.
Okay. So one thing I'd been thinking about is sort of the basics around PPE, right? Even, when you get caught, obviously in the US, PPE should not ordinarily be a problem. But when you get caught with a very high demand in a short period of time, you get behind the 8 ball and it doesn't work out. It's going to be worse for us because this is the same time when all the rich countries are trying to buy it. So I would imagine that for the next 6 months, 8 months, 9 months, you're not going to be able to go to China and buy quality PPE. What can we do? There are ways to improvise, even though it may be at obviously less efficiency, less efficiency of producing it and not the highest quality. But if we say, well, we don't really want to get to the place where we're putting a lot of people on oxygen therapy in Nigeria or in Africa because we don't have it. Let everybody just wear masks, right? Are there ways to improvise so that locally a lot of that can be produced in some way, and you kind of hope that the efficiency of the transmission is slowed down?
I think that my own sense is this: if this thing is pushed back, we're going to be lucky to get PPEs. The real question for me is different. And remember, the PPEs come in two forms, right? There's a simple surgical mask. We have it all over the house here because Chinwe changes in the garage before she comes in after coming back from work. And so, and there's the KN95, they call it, which filters much more of the particles out. What I'm hearing, I cannot mention the government agency that I'm talking to because they won't let me do that, is that the PPEs themselves, they can source them, and they're doing that now. The problem they have is how will they distribute them to the major sites? Currently, we only have 6 testing sites in Nigeria. I said they're going to bring 13 on board eventually. That's what the Nigerian CDC says. So the surgical mask everybody has to wear. The problem is, even if you get those, are they reusable, right? And when you start to see a lot of patients, that's why it's scarce in this place, because you use, I think one of the governors said, instead of using 1,000 a month, you're using 1,000 a day. So are we going to have enough? And can we begin to produce or get creative? I think everything has to be planning. We need to start stocking them up now, because the cases are mounting. They're largely in the urban areas for the most part. Mostly they have the private hospitals, but they're mounting. Everything is about preparedness. I don't worry much about that. I worry a lot more about, how do you maintain the supply that you have? And I haven't heard anything yet. The Chinese government, I heard, sent a ton of them to Nigeria with 30 Chinese doctors. I don't know what we'll achieve with the doctors, but at least the tons of PPE that they sent will be great. We just learned a few days ago, maybe even yesterday, that Nigerian doctor passed away in Lagos. He had COVID patients in his clinic. He died a week later. And again, it was, I think, lack of PPE or even the knowledge that this is happening. So you may have seen the patient with common cold, not knowing that they have COVID. I'm actually scared. If that's a private hospital that this is happening in the neighborhood, then you wonder what that patient, where they've spread that disease now. Again, how well can we maintain this PPE will be the major problem.
Okay.
All right.
Dr. Umaru.
Yes, sir.
Please go ahead.
Thank you very much. Can you hear me?
Yes.
Yeah, thank you very much for your excellent presentation, sir. I think you've put the whole discussion into proper context, which is the Nigerian experience. And yes, it's quite scary. And realistically, all the things you have enumerated, we don't see them happening, okay? So I think the questions some of us are asking, one, I mean, in view of the fact that these things will probably not happen and we are facing a disaster, what kind of context-specific solutions can we bring to bear? And prevention is key, but I think there are important issues that have been raised here that we have to look more into with regards to environment, and that's the issue of vaccines, you understand? I agree that people have individual fears about vaccines, but at a governmental level, Nigeria, Africa, you understand? How do we get involved in the trials? Because I know ethically, I mean, your participation in a research initiative also means that probably you'll be a beneficiary, So at the government to the vaccine company levels, you understand, how do we start looking about taking care of our interests in the long run, providing ourselves as a trial locations for some of these vaccines, not the Chinese type, but the types we've heard about here. Same thing with clinical trials. I mean, I'm aware there's Solidarity trial, which is global. Even here in Canada, they've started their chloroquine trials in Alberta. Are we also leveraging upon this to be beneficiaries of these initiatives if the well-structured studies bring out results? Then something I wanted to also bring up is that I think this will go to the organizers of this excellent presentation, but I think the economics, we are not actually engaging with that, which is a topical debate now in Nigeria. Lock down everybody to stop the infection, but starve them to death. You understand? So our own contextual reality again in Africa is, what should we? How do we evolve a system that works for us? You understand? We're locking down for how long? You understand? We are modeling using what data? You understand? We've only tested 6,000 people so far. You understand? Is that enough to give you data to model an epidemic? I don't think it is. You understand? So I think a critical key that maybe as we go forward is to bring in the developmental experts to also put this in context. Where are we going to? And finally, sir, yes, you raised very good points about the CPAP machines and co. With regards to CPAP, I just want to ask, the risk of aerosolization, is that a clear and present danger with that? Thank you very much.
So thank you. Let me take the last question. So here's what we're doing. You're absolutely correct. For those in the audience who are not medical, aerosolization pretty much means that with CPAP machines, you can actually create, droplets of the virus that makes it hang around more in the air at a much higher dose because of the nature of those machines. So what we've done is that we partner with an MIT lab and created something they call the hood or helmet. The idea behind that is that it has a way of keeping that confined. So the accessories to the CPAP and the BiPAP machines, we've worked that out very well. But we want to really work out more now, and this is what gives me concern, is not so much getting the machines there, is can we train people to be able to use them? Because ventilators, machines in the hands of untrained people can also kill the patients. I think, but you raise other questions that are important to address. Vaccine trial. Let me quickly demystify this nonsense because I think it's important. Look, for those of us in our 50s, we had smallpox vaccines. We had BCGs. It was universal in Nigeria. So what changed?
Exactly.
What changed, right? I think here's what changed. As a country and as a people, we put a lot on government. And we haven't done a good job of owning anything. So Igor and I have training grants in Nigeria. And every time I go to teach, I'll be told for our NIH grants, Prof, you guys are doing well in America, there's nothing we can do here. There's no this, there's no that, there's no this. And I listen to them. These are some are professors, some are lecturers, or all of them are either PhDs or MDs, doctors. So I ask them, everybody each time one simple question. Do you get paid? And they say yes. Is your salary guaranteed? And they say yes. Will you lose your job tomorrow? They say no, not likely. I say, well, I get paid, but my salary is not guaranteed. I have to bring grants to support my salary. So I'm confused. If you're getting paid to be a professor or a lecturer and you're doing your job, I don't know why we cannot become advocates for these programs. Clinical trials are not going to drop from heaven. We've got to advocate for them. And I think what you're beginning to see, and we had this problem with I'm blanking on the polio vaccine, where there was a resurgence in the North again, it was all politics, where people were playing politics with the lives of their own people. And I'll tell my colleagues here who want to go help, and this politics, Ogbenga your colors. I think we've got to own it. If we form advocacy groups and begin to advocate for this, I think we'll be okay. If you do clinical trials, there has to be trustworthiness as well. I don't think we've done a good job of that either. But for COVID-19, I think we can let the trials be done as it's been done. This is just biology. If it's done well, the key issue is what Jide said earlier on. Who is going to distribute it? Gavi is there, WHO is there, but do we have acceptability? The acceptability is really the issue. I don't think that's a government issue. I think government has to have a massive campaign on this, very important, but people have to own it as well. Advocacy from the governors, senators, House of Rep, people, market women, market men, organization, I don't know. The grassroots has to figure out a way to address that. Lastly, economics. We're dealing with that here. I was watching the news last night, and people are protesting in Michigan, in Virginia, and one other state. And the issue really has to do with that. People don't want to go through the lockdown anymore. They really want to go back to work. I think for us in Nigeria, it's the same thing. Some states are beginning to distribute food items, right, to people. Others just don't care. Again, it goes back to what do we own? The government is spending so much money importing Chinese doctors. I don't know what these doctors will do differently that some of us cannot do via webinars to address this issue with our colleagues at home. The issue I was told is that when you import doctors home, you get a contract and you can bid on that contract and you can raise a ton of money. The money to bring 30 Chinese doctors to Nigeria can feed the people in place where I grew up in Yaba, Butemeta, in some of the nearby slums there. So the point I want to make is that I think the economics matter, but there has to be a way to create advocacy. I mean, your platform here, King's College Old Boys Association, is powerful. It would be great if you can begin to get some of your governor colleagues, senator colleagues, and get them to start thinking about these things as well. So that way we all own the problem, not just the government alone, because I don't see this coming from the government. They're supposed to lead, but I don't see it happening. Sorry, I got a bit angry there, but you know, it's the passion.
This is Igor. Can I make a comment?
Please go ahead, Professor.
Yeah. So thank you, Benga. I really, really appreciate the effort that you and your group are making from taking this from just a discussion into practical ways to dealing with the problem in Nigeria. I think that should be highly commended. We have to find a solution to our problem. And I think that is the issue that we have in Africa. We always, almost always, look up to other countries. It's either we're looking up to UK, we're looking up to the US, and now we're looking up to China. One thing that this epidemic has taught everybody is that sometimes the solution you're looking for is right there in your face. So when the issue of PPE came, we didn't have PPE. I'm an infectious disease doctor here in Atlanta, in the US. We couldn't find N95 masks to wear. We didn't have enough even gowns to wear. We didn't have the shields to wear. And what did we do? We have a Georgia Tech, which is an institute of technology here. All of us came together and we put our head together and said, we cannot just let this destroy us. We're going to figure out a way. And they all came and they started producing some of these equipment for us. They are not fancy, but they did the job. You know, if I wore what they produced, I felt safe going into the rooms of my patient with COVID. And when Ebola came, that was, I knew we, here at Emory, we were a center for treatment of Ebola, and many of the Nigerians government officials came looking for PPE, looking for all kinds of stuff. And I remember talking to one of the commissioners from one of the states that, so if you're going to import PPE from the US, you know, the amount of money you will spend on importing 100 PPE from the US will probably make 1 million PPE if you can figure out a way to put a team together to improvise back home where you are. They didn't want to listen to me. They said, no, it has to meet WHO specification and all of those. I said, well, Nigeria is an independent country. They can do what they want to do. The most important thing is that you want to protect your people. So the reason I'm saying is that there are some things that we can do at home in Nigeria to be prepared for this. There are some solutions that we can. Everything doesn't have to necessarily come from outside of the country. There are things that we can do to prepare. Nigeria can make masks. It may not be as efficient as the N95 that we have here, but they could do it and it will be better than having nothing. Nigeria can come up with ways of sterilizing N95. That's one of the things we have to do. We were in significant shortage of N95 here in Atlanta. We came up, we met with our partners in bioengineering, and it's like, how do we sterilize what we have? We know it's not the ideal. We would like to have fresh new ones. We don't have fresh new ones. How do we deal with that? Nigerian could do that. And so I don't know if there's a way to reach out. And I think, like Benga said, this is the time they need to start planning. How do we produce PPE? How do we produce a mask for our first responders? How do we train people to use these equipment? How do we use things like CPAP? So this is the time, right now we have what, about 400 or 500 cases in Nigeria. This is the time to start preparing for those things and to encourage, encourage people from relying on foreign help. it's the reliance on foreign help. Everything that you have to do, you have to rely on foreign help. So give the issue of testing, for example. There's no reason why labs in our major university cannot have homegrown testing kits. When this testing issue came up in the US, many labs started developing their homegrown kits. Many of the labs I've been to in Nigeria have the Abbott equipment and the Roche equipment for RT-PCR. They can develop their testing. They can validate them. There's no reason why they have to import all of those, because that is what we did here in Atlanta. All the hospitals here in town now have the ability to make their own testing. And there are people that I have met in Nigeria that have the same capability and that are trained and can do these things. And I think we need to begin to let them know they can do more than they are trying to do. And the government should empower people to do things and use homemade things. I'll stop there.
Okay. Thanks, Professor. I think there's a hand raised by Patricia Woody, and then after that, Dr. Keshinro as well. Please go ahead, Dr. Woody.
Thanks, Ade. I just wanted to respond to the comment about involving Nigeria in clinical trials. I've worked in clinical trials a lot, and the healthcare infrastructure is inadequate, but we are not ready. We cannot do clinical trials. I can't see where, because there's like Dr. Gbenga said, there's the issue of trust. You need trained people to give vaccines. You need to, it takes a while to build up the capacity to participate in clinical trials. So we've been so behind in building up our infrastructure. That's why we're talking about COVID in the context of Nigeria. We are behind on several things, our healthcare system, our clinical trial infrastructure. And then the other comment I wanted to make was regarding the age. The median age of Nigeria is about 18, 20 years old. So if age is what is pushing the mortality, we may likely see mild and moderate infection. However, the age of our healthcare workers is not 18 and 20 years old. So it won't be surprising to see more severe disease and death among our healthcare workers. And maybe, in planning for COVID, there should be more thought in how to protect the healthcare workers. We are actually, like Dr. Baker said, Africa has only like 3% of the healthcare workforce. And maybe we should be more aggressive in protecting them as we are planning. I mean, I don't know who here is involved in planning how to handle COVID, but maybe we should be thinking about that a little bit more. Thanks.
Okay, thank you so much. Dr. Keshinro, you're open now. You can unmute yourself.
Okay, thanks. I just want, sorry, Patricia, I'm going to disagree with you a bit. So yes, we have big problems about capacity in Nigeria, but we actually do clinical trials, or we still do. I remember we have had at least 2 Ebola vaccine trials. One already is published in the Lancet. That's the GSK vaccine trial. So the capacity is there. It's just for us to reach out. The way it was done for us is that we have a partnership with the US, or what do you call it now? I'm trying to remember, they've changed their name, the Walter Reed Army Institute of Research. So they have a clinical research center in Nigeria linked with the Nigerian military, and they are doing a great job. So the capacity is there, and I agree, if you carry out the research in the country, the chances of having access early is higher. So please, let's think about Nigeria in all what we do. Still in that same vein, what you said last about the age, the fact that the medical workers are the ones going to bear the brunt of this thing is very true. Right now in Kano, a very close friend and colleague, is actually the top most infectious disease physician in Nigeria, is in quarantine for COVID. And not just him, but 3 other members of the task force that has 5 members. All of 6 members, only the governor and the commissioner for health are not affected. So that tells you something is fundamentally wrong if the people supposed to be taking care of the whole state are already infected. And yes, there are so many things wrong with Nigeria, but one thing I think we all can contribute is also information. I look at the amount of literature out there. The average person working in Nigeria, the average, let's not even talk about the local doctor in the field. Let's talk about the academicians, the professors of medicine. They haven't seen this stuff. And they may not be interested in reading them, but we could share our slides like Professor Fotokun, what you presented was awesome. I mean, you could share some of these things. We can have more webinars with them, talk to them, encourage them. It's quite tough out there, and they are bloody distracted. Like what Vega said, Yinka told me the same thing some years back when I was joking about when he had associate professorships then in about 3 places. He said he has to earn his living. But the guy in Nigeria sits down and he gets his salary at the end of the month, whether he works or not. But now that this thing has come home to the medical profession, I think people will listen more to us. And we can share knowledge with them, share with them practical ways of doing things, rather than always thinking big stuff, import doctors from China, import this, import that, import this. I think if we can just try, I know it's not easy, but please let's not give up on Nigeria. Thanks.
Okay, thank you. I think, please hang on, Dr. Chinwe Ogeregbe has a question for you.
Hi, nice presentation, please, Williams. Nice presentation from everybody, and I'll be very brief. I had a quick question for Mr. Jide Keshinro, because he said he disagreed with Patricia Wodi. My hospital happens to be one of about 18 institutions in New Jersey, one of the largest systems. It's called Hackensack Meridian Health. And we happen to be participating in quite a few trials, and about 5 of them that I'm sub-investigator in helping out. When we signed up for these trials, and I mentioned them, they showed how many sites they had all over the world. And I really didn't see Nigeria. I didn't even see Africa. So you said the military, Nigerian military thing had a lot of capacity and they're doing well. And Ms. Wodi said the opposite. So I tend to believe her in a way, because from the lists I saw, we're participating in the hydroxychloroquine trials, remdesivir by Gilead, salirumab by Regeneron, right? Also Genentech's TOSI study, and most recently, dantrolene study. And when you sign up for these studies, the financial disclosure form shows all over the world where the trials are happening. I don't see. We don't have patients, but we don't even have the thought of including them. That's what I'm saying. So we need to advocate for them to happen. So if Jide has contacts, he should try to bring those trials to Nigeria, because they'll actually help to see if our patients will do better. Then very quickly, do you want to respond, or you want me to say my perspective as a frontline person?
No, I don't need to respond really. Okay. Given what we have in Nigeria, I think 1 or 2 sites is too few, but they are there. We just have to look for them, and I will gladly help link people up.
Okay. All right. Then in terms of the frontline perspective, what happened, what we saw in my hospital was a lot of misinformation given to physicians by the CDC. A lot of physicians were following very avidly what the CDC had said at the very beginning. We had the first patient in New Jersey, which was March 2nd in our hospital. At that time, the CDC was saying all we needed as healthcare professionals was the surgery mask, which is a little mask you slip over your ears. You didn't really need N95. Then a few days after, they'll say, oh yeah, it would be a good idea if you had enough. So it was back and forth, and many of my colleagues were sticking to that. Some would use only surgery masks and some would not. So because of that, a lot of my colleagues fell ill, unfortunately. Out of about 17 attendings, about 7 of them got admitted, 1 got intubated, and 1 in another hospital actually died. So I think that's from gross misinformation from the government. and they were trying to, I think, maybe save money on PPE, and they were not giving this, as they should have. So we hope that shouldn't happen to Nigeria now that we know that's very important. Now, because I want to be cautiously optimistic that since we are a middle bump population, right, we may not have as many cases, but like Benga said, we should plan for the worst. So everybody who has contacts or connections in Nigeria, try very hard to begin the conversation or continue the conversation and see what you can do in your own space, what you can do to help. So I'm doing the same thing, trying to help in every way, mostly by education. We were asked to do different webinars for different contacts we have in Nigeria, and a lot of people were attending. So whatever we can do, those of us in the diaspora, to help the homeland, I think we should. Thank you.
Okay, thank you so much for that, Doctor. I see Dr. Olutoye has his hand up, so let's unmute him.
Thank you. This is Yinka Olutoye. Glad to be part of the group. Again, really impressed by all that I've heard and all the folks that have contributed to this forum. I just wanted to say a couple of points just to put into perspective. I know we've all heard about how this is a condition that adversely affects the elderly more than others. While that is true, I think it's still important for people to realize that out of the deaths, yet about 40–50% may be the elderly. But guess what? The rest are not elderly. So even if we do not have a lot of a huge elderly population in Nigeria, even those young ones can still get affected. In fact, most of the healthcare workers that are affected are not within the elderly age group. And so healthcare workers being at the front line is key, and I'll talk about that in a few minutes, but even the young can be affected. We've had young folks die from this condition here in the US as well. So the tendency is for people to think, well, only the old people are affected, I'm going to be fine, and really not pay attention to it. That is not true. I mean, you just have to look at the statistics all around. There are young people dying, maybe not to the extent as which the elderly are, but otherwise, quote unquote, healthy adults are being afflicted as well. Not to the extent that the elderly are, for sure, but they're not preserved to the extent that they may think. And so applying the appropriate cautions, they may have the resilience to withstand it, but still I think they can afford to be cavalier. The healthcare workers at the front line are definitely key. And I think it was really sad to hear from Dr. Keshinra about the experience from a task force where 60% of them have been sidelined because of exposure. One of the things we did in our setups here, which many places are doing, is when you get into a pandemic, first thing you want to do is ensure that you never run out of your workforce. And so a lot of things that need to happen will be for people to cohort themselves. So you're not mixed. I mean, first of all, all the meetings have to be remote, so you're not all in the same environment, but you're not all in the same circles, so you can't risk everybody being incapacitated at the same time. That has to go for those in the task force leading the exercise, even for those at the front line that are working, walk in cohorts, walk in groups that do not interact and do not interface, so you can at least keep your healthcare group sustained. All sorts of things have been done in terms of masking. I think we talked about that. The truth of it is any mask is better than no mask. So even if it's a cloth mask or whatever people can do, it would not protect you as much, but at least will protect other people from you. Remember that the N95 is probably the best protection for you for droplets, but even anything over your face prevents you from spewing out your droplets to the next person around. If everybody goes around wearing masks. Now remember back in the Spanish flu in the 1919s, they all wore masks. I mean, can you imagine what those masks were? They were probably just pieces of cloth that people put over their face, bandanas, etc. The goal of this is just to stop you spewing stuff around. We talked about the high slum areas, the Marocos, the Makokos, etc. You can't isolate people. So the best thing you can do is really just get people around to do whatever they can to protect themselves. There's no question we're in a place like Nigeria where we know that prevention is really our best effort. Where universal masking, it doesn't cost much. I mean, by tomorrow you have a bunch of Ankaras with COVID-19 written on it that people are making masks with that can become an enterprise. You can do whatever you can to get this out so people are wearing masks and people are doing the best they can to protect themselves. You can't isolate to the extent, We can't do as much contact tracing because we don't have the manpower. But one thing we can do is protect ourselves to the extent that we can, be aware of what's going to happen. I think Dr. Fotokun's point is a good one. We can't wait to import all these things from outside. We have to do what we can and innovate from within. I mean, Nigeria is known for innovation when we really come to it. And yes, many of it is financial driven, but at times there has to be a greater societal need that drives our innovation. And I think this is the opportunity to do that. Yes, we don't have elaborate, extensive infrastructure for clinical trials, but there is something there that is there, and I think we just need to start that. If we don't start it now, next epidemic or next pandemic, we won't have any to. So this is the time to build on whatever little we have, continue to improve on it, so by the next time we'll be there. So I think, the point has been made, sharing the information with those in Nigeria so they're aware of what's going on. Right now, it's the way the US was in early February. This is a Chinese disease. It's not coming over here. Well, guess what? It's already in Nigeria and it's going to spread. And we have less ability to contain it in Nigeria. It's high time for all the professionals, and the politicians, the public, the lay folks to actually be aware of what this involves and what this, what this would result in if we don't do much and do the bit we can. Again, thanks to everyone for all their input, and I think it's great to get everyone together. Florian.
Florian, Dr. Lutoye, I'm glad that you did not make me sing the school song today.
Don't let's go there. Don't let's go there.
Well, so we have lots of other people from other schools here, so we don't want to scare them when we scream. Thank you all. With that, I think we've had a wonderful couple of hours. We went over, which is always a good sign of an interesting discussion. I saw a lot of people coming in and out. So although we never reached the top number of about 50 who registered, I think because people were circling in and out, we probably got something at about 40 or so who got this. All of this is recorded. So without objection, we're going to place it on YouTube, and it will be, we'll direct people there with links, and hopefully it will, go around on social media in Nigeria. There are some Nigerian doctors and others on the call here. And so hopefully because of that, it will be of a wider use because a lot of very interesting and educational items have been said here today. And I wish you all the best, and looking forward to the day when this is over and we can all meet, not in the not too distant future at some point. We'd love to get the high-powered medical profession, and really thank you all, in person for all the wonderful work you did for the world. Thank you.
Thank you. Thank you very much.
Bye-bye.
Bye.
Bye. Thank you.
Thanks very much, Ade.
Okay.
Good job.
Bye, Presido. See you later.